Welcome, everyone, and thank you for joining us this afternoon. My name is Angela Vargas, and I'm the president of the Latino Mental Health Association of New Jersey. And we are so excited on behalf of the association. We are very excited and grateful to Dr. Paula Muer for extending this partnership and the conversation that is so critical to be had. We really look forward to continuing the partnership alive and to continuing giving voice to the condition that is dementia, to individuals who live with it on a daily basis, and to caregivers who also experience their own process of caregiving for individuals with dementia. So thank you again for being here. I think we anticipate this to be a very informative panel, but also one that can be open for questions and dialogue. So if anyone feels inclined, please feel free to use the chat function for that, and I'll keep an eye on that. And with that, I'll turn it over to you.
Thank you. Thank you so much, Angela. And thank you everyone for joining us today. This has been a project for a couple of years now with the Dementia Action Alliance. Dr. Vargas said, I'm Paula Muer. I'm the founder of Caregiving 360. But in this function today, I'm talking on behalf of the Dementia Action Alliance. And this was a project that was started over 2 years ago, calling all the voices of the Latino community. And it was a beautiful project where we had the opportunity to interview people living with dementia as well as their care partners. And here we have panelists, two wonderful care partners, Carlos and Juan Carlos. Both of them are caring for their loved ones. We also wanted to have one person that we interviewed 2 years ago, Mayra Garcia. Unfortunately, she couldn't be here today, but I wanted to share her experience, and we're going to play a video of where I spoke with her 2 years ago. So please, I'm going to share my screen and share the video with all of you.
Yes, I'm very happy to do that. And thank you so much for reaching out to me. I appreciate that very much. I am the daughter of Cuban immigrants. They came over from Cuba straight to New Jersey because my mother's two sisters had all made the trek to New Jersey. And so that's where I was born. My sister was born in Cuba. I was born in the US. So I was the first among the family members. I had a wonderful growing up. We were very poor, but we didn't know that we were poor. And we went to church every week. Everybody in my family could sing. And so it was just, there was beautiful music all the time. Elementary school, I couldn't understand why all the children were crying on the first day of elementary school in, you know, baby land. And I couldn't understand why they were so upset. I loved it from the very first moment. So I excelled in all aspects of school. I had I was very fortunate to have a beautiful music teacher in high school. I signed up for choir because I thought it would be an easy A. I never thought about music as a career or anything like that. It was just what we did at our house. And that very first day, I was just like all of the new students, all of the freshmen. I had to have a little test with the music teacher. And immediately, because I could play the piano and I could sing, immediately she said, from now on, I will be your music teacher and your voice teacher. And that was the case all the way through elementary. Then I majored in music in college, had a wonderful career. I had opportunities to perform at the Repertorio Español of New York City because I was living in New York, in the New Jersey, New York area. And I had opportunities to perform at Avery Fisher Hall in New York in so many different opportunities. I already mentioned Repertorio Español, but I also was Jewish temples because, wherever I could sing, I was there. And so that was the beginning of my life. I then transitioned from when my second son was born. I realized that I could no longer do all of the travel that's related to performance. And so, that was hard. That was hard because I had just been granted a part in a play, and I had to say no because it was a traveling show and I would not be able to do that with two sons. So I migrated into the field of fundraising, university and school fundraising. And I found that that was really fun and wonderful, and that I could make a difference at all of these educational organizations. I made it to the level of vice president at two universities. And unfortunately, that was when my disease was starting to take hold. The first thing that I was seeking was, I knew that there was something wrong. I knew that my aunt had Alzheimer's. So I thought that I had Alzheimer's, but my neurologist said, no, 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 what you have is ADD. And so when I heard the ADD designation, I literally burst into tears of joy because I knew I had seen it with my aunts, how difficult and how painful Alzheimer's is. And I was just thrilled that I had been given the ADD moniker. So I was on those drugs for a number of years, but I knew that things still weren't right. It took quite a long time, and it wasn't until COVID that I found a neuropsychiatrist who gave me a battering of testing, 8 hours, literally 8 hours of testing in one day. It was very, very challenging. And at the end of the day, after she had really taken hold of all of the pieces, she brought me back to her place and shared with me that what I had was early stage Alzheimer's disease. And I I think that I accepted that very easily because it was, in a way, something that I was expecting my whole life. Not my whole life, but my adult life. And so it was very hard on my husband, extremely hard. He really thought that I was just not giving it enough time with the other drugs that I was taking for ADD, etc. And so my neuropsychiatrist suggested I get involved with the Alzheimer's Association and I get myself into a clinical trial. I know that I'm doing something not just for myself, it's not just me, but it's for all of those other people just like me who have this disease and don't know how to do the things that they used to be able to do. And so that is my story. And I feel that I have been given a gift because I can help other people. I can help the scientists by sharing my experiences. And I'm also just enjoying life.
Oh, that's
So thank you.
wonderful. But yes, I wanted to share my story because it's very telling all what she went through. Very often, early onset Alzheimer is misdiagnosed. She's not the first one to go through that experience. And then participating in clinical trial and sharing her experience of being a wonderful advocate for the disease for people living with dementia and also for care partners. So thank you for giving me the opportunity to share mine. And now let's start with our wonderful panelists. So if with the question for them to share their experiences. So I would like to start with you, Juan Carlos. could you tell us what was your experience with your mom? And how did you seek the diagnosis? How was your experience going through the diagnosis of the disease?
Yes, my name is Juan Carlos Saldivar. I'm a filmmaker and video artist, and now I'm a professor at SUNY at Buffalo. There had been signs, but we kind of missed them. I think this happens a lot. So what happened was my father got ill. My father was a little older than my mom. They had been together for 50 years, and I had just finished a job in California and came to stay with them because I could take a little time off, and I wanted to just hang out with them whenever. I always did that between jobs, and I started noticing that she was really stressed out because my father was ill. He was at the end of his life. He was sleeping a lot. So she was kind of alone in the house for the most part, even though he was here. And he was a little depressed. He had survived cancer, but he didn't quite survive the depression that came after all of the treatments and losing his sense of taste and all of this stuff. And so then I decided to stay and help because I really felt that she was really stressed out. And then my father passed away while I was here, and immediately the day after, she was very confused. She didn't know where she was, and so a big part of it, I think, was triggered by the loss, by the grief. This idea that I guess she's always been expecting that he was gonna die before her. So that's kind of how it started, and then of course I stayed to continue to accompany her and see what was happening. Then I took her to a neurologist, and they did a couple of tests, and she was diagnosed with mild cognitive impairment, and at that point, I think they put her on a psychotropic drug. And then what happened? She started to have heart problems, and which she had never really had before, and I had to run her to the emergency room a couple of times, and in one of those times, they decided they had to put stents in her artery, and they gave her anesthesia, and the anesthesia, I think, was sort of the last straw. So she never really recovered from the anesthesia. Like that sort of jumped all of the behaviors and things to what they say is going to happen, 10 years from now. And then it took months. It turned out it was ironic because then she was so agitated by the anesthesia that they couldn't really do the operation, so they had to wait and without any anesthesia beginning. But she never recovered from that. And that's kind of when you could really tell, like, her functions really declined, and she was still able to talk and walk, and she was physically active otherwise. So the first 4 years for me were very difficult. I didn't know anything about it. I tried to learn as much as possible, like most people do, but it was one crisis after the other. I think it was very difficult for her because she was still aware enough that she knew what was happening, and it frightened her. So, as a matter of fact, I think that's what happens in the early stages. Part of the reason that they're so difficult is because they still have executive function. So they become aware of what's happening, and that's very, very frightening to them. And so then I was with her for 4 years. I was doing it by myself, and it was getting to the point where I was kind of burning out. I hadn't worked. I went back to school when I got some hours for her Medicare, so I had somebody who could come for a few hours, and I could start going back to school. And I got my massage therapy license because I wanted to learn more about the body. I certainly couldn't make a movie at that moment because I couldn't go away and leave her alone. And so it was in school that I started to then really go deeply into my research, and I found a few methods that have been around for a long time that I hadn't really heard of, and so I started to try them out at home, and that made all of the difference, but not enough. So at that point, my sisters decided that the best thing was to put her in an assisted living facility. So we talked about it, and I went along, and we did that for a year. But she wasn't really happy. It was very difficult for me because it was far away, and I had to go. I had to go. I want to go every day. And so a year after that, something happened, and I brought her back. And during the time that she was there, I was able to go deeper into some of my research. And then I also decided that one way for me to incorporate, I had to change my life. So I began to work on a film project about dementia and sort of my own experience. Because I figure the more I talk to people, the more I realized that many people were going through the same thing in silence. And at the time, I hadn't seen anything on television or anywhere, right? Like people always have very negative things to say about dementia, and that's all you hear. So I that's how my journey has gone so far. So now we're on our ninth year of the journey. She's at home. She's happy. Our methods continue to work, and I'm working on a film to try to let people know what that soup is, that has worked for me, and then maybe they can find their own soup. But most of all, I'm interested in really trying to change the language that we use to speak about dementia because we don't have a cure. It's not going away. So we need to learn how to live with it. And I think by using a lot of negative language, we're setting up people for failure or for expecting failure. And there's a lot of gifts that come along with dementia that we're missing, not just for us, but for humanity. I mean, when you look around where we are, our society talks a lot about, taking yoga, living in the moment. But most people can't, they go crazy themselves if they try to, be with somebody who has no choice but to live in the moment. We don't understand what that means. And I think there has to be more dialogue about what does it mean to be really, truly in the moment and to communicate emotionally without expectations of language or all these other things that we're using right now to communicate. And so that's what I'm working on. She stopped her mobility. She fell about 2 months ago. So now she's really afraid to walk. So she's bedridden now. But I have some help, and my employer has been really supportive. So they're supporting the project and my work with her. And I'm able to commute to work. So I was able to teach remotely half of the time. And that's kind of where we are now.
Great. Thank you for sharing that, Juan Carlos. Thank you so much. And now I want to introduce Carlos, who is joining us from Sacramento. He's also a wonderful care partner for his father. Please tell us your story. How was the diagnosis for your dad, and how has been your journey so far?
The journey so far, it's full of emotions on this roller coaster ride. But if I reflect back to when we got a diagnosis, it was roughly about this time, 10 years ago. My brother took my dad to his primary care physician after we've had some concerns from my dad's dentist and other people in my dad's hemisphere. And the doctor gave him an assessment, determined that he had mild cognitive impairment, prescribed some medications, and said that this will help slow down any progression of memory loss. And that was basically it. There was no pamphlet or information on resources to follow up with to help navigate what steps are next. And it was kind of hard because we were left in the dark. The doctor did say that Dad may need to have some supervision at home. And between me and my brother, the discussions we had led to me coming home first to support our dad with his day-to-day living situation. And we didn't seem to think that anything was really wrong with him because he seemed as normal as possible. He still navigated his surroundings fairly well. He would show up to different places on the wrong day, but for the most part, he seemed all together. It was when I moved back home, we started butting head, ended up pressing the new primary care physician for my dad to maybe get a referral to a neurology department, just to see if it was Alzheimer's or kind of investigate what was going on with our dad. In 2017, after several months of waiting, we got a diagnosis of Alzheimer's dementia, and still I had no clue what we were getting into. It was a weird journey. I remember the social worker giving us a pamphlet and pretty much just saying, if you have any questions, please give us a call. But there was no really follow-up to understanding what we were getting into as a family. There wasn't no guide or step-by-step instructions to take to ensure that we were doing the necessary things early on to support our dad. It wasn't until I called the Alzheimer's Association one night in frustration and sadness and wanted some support. I wanted to join a workshop that was coming up about how to talk to somebody with Alzheimer's. And I immediately found that this is where I need to kind of put my efforts into understanding what Alzheimer's is. I ended up getting into a caregiver support group, immediately felt at home with people who were already on the journey, learning from, I call it my elder mentors that were years along with their loved ones or barely starting out, but also going through their own emotions, their challenges with what they were facing. I ended up learning about being a caregiver, identifying that I was one of the many that are out there right now that are doing this work in isolation and without really being seen and heard, unless you went to a caregiver support group and being surrounded by others who understood immediately why you were there and why you took the time to invest in yourself. So that's pretty much where I'm at. And like fast forward to now, I've been learning how to walk my dad home, learning about what dignity is. I've had to unlearn a lot of things I thought I knew about autonomy, independence, aging. I've had to learn my dad in a different way. I say that I've learned more in the last 5 to 10 years than the first 50. It's been a transformation for me to build a relationship with dementia and the person I call dad. There's two different people. There's two different approaches. It's a strategy that takes a lot of time to practice and to understand yourself in the process. Because I feel if I am able to communicate in a calm, concise manner with both dementia and my dad, I can get results. If I'm stressed out, if I'm nervous, if I'm fearful, dementia picks up on it and amplifies it with my dad. And then we have a problem because I can't control those fears that dementia stirs up inside my dad. But it's a challenge. If you really want to take a microscope and look at our story, you see that there's a lot of things that I've utilized and practiced over the years that make it work. We've built a relationship through humor, through life that my dad has pretty much laid down. He's an artist. He is a really jolly person. He's witty and he's compassionate. And if you let him live, he's going to take advantage of it and live to the fullest. No matter if he's sitting in his chair, drawing all day and not wanting to be bothered because you have a plate of food and he just wants to draw because he's in that moment. He's in that zone. This is his happy place. That's where you leave him. But we can't leave him in a chair all day long. He needs to stretch his legs. He needs to, get his blood flowing and moving and participating in his own socialization with the world. So we try as much as we can, implement a lot of non-pharmaceutical intervention that really encourages him to love life. And at the end of the day, if I ask him, what are you grateful for? His recent response is, life. And I think that encompasses everything that he feels, that life is present in the moment and he's content.
Thank you both for sharing your very unique but also common experiences, both at the onset of learning about the diagnosis and also just over time. And I think you both really spoke beautifully to what you're seeing in your loved ones and also your own experiences. I have a quick question. I think most people, when we think about Alzheimer's dementia, we think memory loss. We know that there is much more nuance to it. And so I'm wondering if you can speak a little bit to whether it's like the earlier on things that you started picking up on. And I, as a psychologist, I'm curious to like the emotional, the behavioral changes, decline. And now I know that I'm adding three parts to this question, but like, and the things that you say, well, maybe, those are the things that I didn't really realize, or we chalk it up to something else.
Memory is a trap. We've made this whole conversation revolve around memory, and we don't even understand memory. We have a lot of misunderstandings of what memory is. We've built a culture that has put all these weight on memory. Memory defines our identity, defines who we are. And of course, we understand why all of those things happen because, science has, we have certain share beliefs about time and space and whatnot, right? So that's just the ocean that we're navigating. But I do think that dementia is coming along to shake those notions up and to go back to other wisdoms that have been there for a long time that we've all known that have nothing to do with memory, that have to do more with all of the things that Carlos is talking about, the value of life, period. The value of well-being, of being respected and seen, which is, being a human being who's alive, and also understanding that we're all decaying, right? We're all going to die, and that's okay, but that we have to value what we have right now until the powers that be, until your heart starts beating and you have to go. So that's one thing, I think. And the other thing is that we also, because of memory, we think that when people can begin to disassociate their past memories of their lives, they stop being who they are. And that breaks my heart because I think that's also the source of a lot of suffering. I'm not the person that I was 10 years ago. I'm so different. I'm not the person that I was 3 years ago. And so are you going to stop talking to me because I've evolved, because I no longer drink, or I no longer like this, or I no longer like that? So when people say they're not my father, or they're not my mother, I'm like, no, you're the problem, right? Like you're not seeing the whole picture, and we need to stop that. We need to stop saying those things because they're just really not true. The person that's in front of you is your loved one. They are the person who lived all this life, whether they remember it or not. And they're alive, and they want to be alive because everybody wants to be alive. So anyway, so that's one thing that I think is really important. It's been really important for me to shift so that I can live, and all the things that Carlos is saying, not be stressed or not be. Of course, we're human. If the night before you didn't sleep, you're gonna lose your patient, and it's not gonna be perfect. It's gonna be up and down. But that's where you need to identify where you need help, right? What are the tougher parts where you need to step out and have somebody else step in for a minute until you can cool off? Because they may not be able to remember the pronouns or your name, but they can certainly read you because the intuitive part is alive and well and not affected by dementia. And 50% of what we're doing right now is looking at each other's body language. And if you were near me, I would be also smelling you and feeling your heat, on a million other things, right? So those things are active and they're real. And just because we haven't studied them or we don't talk about them, doesn't mean that they don't exist. And we need to start shifting to valuing those forms of being, like that, emotions are important, that they're not something that should be erased. We need to accept that they're in the world and then find a way to live with them, right? And to mitigate them so that we don't get into crisis. One of the people that has been really helpful to me is Dr. Cameron Camp. And one of the things that he talks about a lot is that if we were to look at the definition of human rights from the UN and we look at how we treat people with dementia, we would fail. half of those things we're not really doing for them, He's like, where are the cognitive ramps? Like Carlos says, they give you a diagnosis. If if you lose your eyesight, you won't leave the hospital without glasses. Or if they cut your leg, they'll give you a wheelchair or crutches. But for people with dementia, they're like, you have dementia, sorry, there's nothing we can do. Come back in 6 months. But there's a lot of things that we can do to live with confusion, the same way that there's a lot of things that we can do with diminishing eyesight or, our physical mobility. There's a lot of things that doctors could be telling people when they give that diagnosis to help their life be better. And I think those are things that need to be talked about and they need to be brought to the foreground.
Absolutely, absolutely. Thank you for sharing, Juan Carlos. And actually, you have been touching many of the areas that we wanted to discuss. I mean, the support of the medical community with the diagnosis. That's what we wanted to talk about, your journey. And if I remember correctly from Carlos' story, I mean, surprisingly, the dentist was the one that noticed that something was going on, which is that he wasn't the primary physician. So we need to bring this to the surface because the medical community, in many cases, is ill-prepared. And the signs, like you were mentioning, Juan Carlos, are there, but we're unsure. So we have to create the tools to better do the diagnosis, not to wait so long. I mean, Mayra told us the struggle that she had. She had a wrong diagnosis for many years that she could have been doing other things in order to deal with the true diagnosis. So I want to talk a little bit. This is still calling all the voices Latino community, and I wanted to see if you, Juan Carlos, and you, Carlos, how do you see the stigmas and the challenges in the Latino community in front of this disease?
I think the main stigma is just not to the Latino community. For men, is like, why do I need to go to a support group? Why do I need to talk about my feelings? Why do I need to talk about my wife or my loved one and their challenges? How's that going to help me? It's like, if something's broken, I'm going to go into the garage and find a tool and fix it. And we've been structured this way as men to take control, take the necessary steps, follow the manual, to do the work and just process it out. And if that's, breaking things here and there and getting angry and frustrated, then that's part of it. But we haven't been given the tools and the resources to reach out to understand our mental health. Caregiving thrusts us into a caregiver crisis. The chronic stress and strain on top of a possible health condition that some of us are going through can exacerbate and grow even larger when we don't release these tensions. We sometimes break and we don't know why. And as a community, I think, as society and community, we need to be open about that. Not just say, hey, you need to fix your mental illness, but more of preventative measures to promote wellness. And that takes education, awareness, understanding, and empathy. Like I said before, I didn't feel comfortable until I went to a support group and understood the others. I saw what they were going through. I wanted to learn more. I wanted to listen. That gave me the opportunity to connect. But there's a lot of people that don't take those steps, or they'll go to a support group and they'll say, oh, it's just too much. There's too much trauma. There's too much sadness. There's too much of that pain that I'm feeling, and I don't want to feel that anymore. How do we expand the approach where we can reach out and uplift others through these moments where they need to have a safety net, they need to have some type of cushion for them to fall upon, where they can feel comfortable, seen and heard in those vulnerable spaces. And I think it's hard to kind of, I guess, unweave what's been woven already, deconstruct that and build a bridge to people to understand that, hey, you're a caregiver. You go over there to your mom's house or to your parents' house, and you're filling prescriptions. You're mowing their lawn. You're doing these extra things because, you just want to help them out. That could be considered part of the care team. And with that may come some frustrations because you may observe some unusual, confusing behaviors that doesn't sit right with you, and you don't know how to process your own emotions. And, having a therapist, going to support groups, having a caregiver coach, having other people talk about this, like on a panel like this, helps people kind of understand that there is help out there, that they're not alone, but it's difficult. And we need to break down those barriers so we can have more access and be more responsible for our well-being.
Absolutely. Thank you. Yes, Juan Carlos.
I just wanted to add, I think stigma is culturally specific, like you're saying, because it manifests itself, based on a certain set of values, right? So at this point, my take on it is that it really has to do with our American culture, because that's where we live. I think in most Latin cultures, elderly people live at home. You don't send them somewhere. And there's a lot of other cultures where taking care of elders is just part of it, right? It's just, people don't question it. But I think we live in a culture that is where there's even a term called human capital, where people are only valued in as much as they can contribute. And so when we associate age with the decline of physical ability and mental abilities, that individual can no longer contribute to that value. And so we don't value them. And I think that because we have that value system, we then come up with these ideologies that are stigmatized and these preconceptions that are just simply not correct. They're not really truthful to what's really happening. So I find that the stigma against dementia is often also linked to the stigma of aging. It's also attached to the stigma of the end of life, which in a culture that only values performance, when somebody is close to life, then they become a liability because, they cost money to be alive instead of them making money for the system or for the societal system that we've created. So I think that's really the problem. And I see it, particularly taking care of a woman, I see it in the healthcare system, talk about pelvic health. Now, I've been talking to all these women who are starting this website. It's a mystery. Women after menopause, they're not part of medical studies. A lot of gynecologists are men. There's no, even only in the last 50 years are women part of medical studies for cardiology, for cardiac disease. So when you go to the doctor, you're being misdiagnosed because the symptoms that they're comparing you to are not the symptoms that are going to manifest in your body as a woman. And so I think all of those things need to be taken into consideration when we talk about stigma, because I just don't think it's just a Hispanic thing. I do think there are certain stigmas within the Latin community that come from other stigmas, like Carlos is saying, which is like the gender, the machismo, sort of legacy and all of that stuff, right? of men not dealing with it. Certainly, those stigmas will be there, but those are stigmas that carry through cultures. They're not necessarily, the patriarchy has been all over the world, right? Racism has been, it boils out through continents, over a series of hundreds of years. So these are things that need to be part of the conversation when we talk about stigma. I don't. So I think they're related. The other thing is that stigma comes from fear, and fear comes from the unknown. And because there's so many unknowns about dementia, it breeds a lot of uncertainty, and that creates fear. And so that, a lot of the time manifests itself as anger towards the situation, which of course can put the person in danger with a caregiver. And that creates a lot of really complex situations that, if we're not talking about the bigger picture, we're never going to be able to untangle completely. So I know it's sort of like a 10,000-foot view of the situation, but I think we have to be careful when we talk about stigma and culture, because it isn't a Black thing, it isn't a Jewish thing, it isn't a Hispanic thing. I think it's really a value system thing, and we have to look at, how are people valued in the culture that I'm in, and how is that stigma playing out those values. That's my take on it at this moment, just from my own experience.
Thank you for the comment. Angela, there was a question in the chat. Do you want to address the question?
Yes, absolutely. So the question is there a stigma in the Latino community about receiving mental health support? And I guess I'll start, and please chime in. I think yes, there is. And I also think that that's a simplistic way of understanding. And Juan Carlos, maybe this speaks a little bit to what you're talking about, is that while it's not traditionally known as the first recourse, I also think when there isn't access to support, when supportive and resources aren't readily available, if they're not integrated into the course of treatment, then that doesn't encourage thinking about the mental health side of things and then taking the next step to receive support. And I think that that's more broadly, right? That doesn't only exist in this conversation or within this condition, but that's a conversation that could be had across conditions, I'll say. But that's my introduction to the question. Carlos and Juan Carlos, I'm curious what you both think.
I think we need to kind of destigmatize what mental health is, because mental health is not mental illness. Alzheimer's and related dementias are not mental illnesses as well. We need to educate that it's a neurodegenerative disease, that the brain is deteriorating, and it may mimic mental illness. And we may think ourselves are crazy, the care partners, because we're going through these challenges with our loved ones that spin us around. And sometimes we don't know which side is up. The challenge is the awareness, the education, the understanding of, I guess, how we can communicate better to encourage people to be more invested in their mental well-being. That well-being is not just physical; it's spiritual. It's mental. It's being connected to community. It's really taking the time to be present with yourself, being grounded enough to let yourself be, and that becoming of yourself is something that we don't really understand, because we think that it's commercialized, that we need to, make so much money, we need to do these things, we need to see those goals as achievement to have class. But the reality is that we are human, and all we need is our family, is our community, is our neighbors to kind of thrive together. And we can be participants in each other's lives as well as our own. But how do you integrate that into the programming of day-to-day life that's out there commercially? If you take all that stuff out and you just live in the moment, you'll find out more about yourself than anything.
Thank you for sharing that, Carlos. In the benefit of time, and I wanted to really address one additional topic that I think is very, very important, because I think we don't talk enough about it either. It's about trauma and how it reflects in the disease. And I remember, Juan Carlos, you shared that with us, that when we were doing the interviews, how you observed the trauma that your mom went through, and even the trauma of yourself, how that experience was reflected through the disease.
Yes, thank you for bringing that up because I do think it's one of those things that gets, it doesn't get enough play or dialogue around it. I think um, there is and this is one of the reasons why personalized care is so important. We need to really push for people to stay home and get personalized care over, when it's not possible. Of course, not everything is possible all the time, right? For some people, a shared care facility is the answer and is the best option. The same way that for some people, medication is the best option, right? But it shouldn't be the go-to option. And I think that we need to always push for individuals to get personalized care because the history of an individual is really important, when you're providing care. And there are so many things. Now we have made a list of all the troublesome behaviors that people with dementia have, right? And we sort of define them, and that's what people are looking for, and that's what people are expecting. But anybody who's been a caregiver will let you know, if you've really lived through it, that any one of those behaviors is really just caused by stress. And if you find the source of the stress and you remove the stress, the situation becomes under control. And so that's the type of care that we need to promote, right? And in that care, it knowing the individual makes the care even better because, if somebody's been sexually molested when they were young and nobody knows that, something as simple as changing their pampers every day or bathing them becomes a traumatic experience for them. And that behavior is never going to subside unless you know that and you can then treat it with that much kindness and that much sympathy and that much care so that that person feels safe right before you do that. And that's just an extreme example. But, most of our community in the United States, particularly this generation that is being affected by dementia at the moment, are immigrants. And there's a lot of trauma that comes from immigration. People of color have a lot of trauma from like living in tough neighborhoods and living with shots or having been beaten or surviving domestic violence and all of the other things that societally people who are oppressed have to suffer through their lives, right? And kind of suck it up. But when it comes when your care when you need to delegate that care to somebody else, it trauma sensitivity needs to be part of what caregivers are trained on, whether you're doing it for your loved one or whether you're working at a facility and doing it for others. There is an organization that I was talking to who started these studies with survivors of the Holocaust, but pretty soon they realized that this didn't just apply to that particular population, that it applied to immigrants, it applied to Black people in the United States, it applied to all sorts of other to women specifically. And so we need to be sensitized to that, and it needs to be part of the dialogue when we're creating educational materials or trainings and things like that. Part of the work that we've been doing in West New York is there is an association, there is a movement to start memory cafes in the United States. And I'm part of a collective that there's about 900 of them in the United States now. They started in Europe, and we want to make that 9,000 in the next 10 years. So there is a collective called the Exhale Collective, and you can look them up. And they now have a national directory of cafes. Pretty soon they are going to start micro grants for individuals who want to start cafes in their communities. And there aren't that many in Spanish. So I just found 2 partners in West New York, and we started one. We've done 7 of them and for Spanish speaking seniors and people living with dementia. And so I invite people to look at the resource and find ways that they can bring that to their communities if possible, because this is a great way for people to get to know their neighbors and talk about these things.
I'm taken away just from the different angles that we touched on. I feel like we just scratched the surface, but you both really just brought it to light in a very powerful way. So thank you to you both for sharing your stories, for your honesty and vulnerability in doing so. Paula, thank you to you as well for bringing us all together, and to everyone who participated in today's meeting. Let's keep this conversation alive. Let's keep our activism alive.